maybe the IT. Okay, thank you. Good morning, everybody, and welcome to the Health and Adult Social Care Scrutiny and Overview Committee. So the May meeting. Before we start, I need to inform you that the meeting is being live streamed and recorded. So item 1, we've got apologies for absence. I've got Chris Schofield and Roy Aldcroft is substituting.
Give Tracy's apologies and Bernie will sub.
Who's given apologies?
Tracy Huffer.
Tracy, okay. Disclosable pecuniary interests. If there are any, please shout out when you become aware and we'll take the appropriate action. Item 3 is the minutes of the meeting held on 28th of March. Is everybody happy that they are a true record? If so, can I have a proposer, please? Thank you, Nick. And Kate, second. So all in favour? Thank you, they're moved. Public question time, we've had none received. Member questions, we have one from Kate. So,
if you hear me okay?
Do you want to read it out for the viewers? Both of them.
Okay, my question is, it's Kate Halliday, I'm councillor for Bellevue Ward. Last summer, the CCG ran a listening exercise for proposals for a new health and wellbeing hub in Shrewsbury, which potentially involves the closure of some of up to 8 GP practices in Shrewsbury.
Sorry, Kate, we've got a bit of disruption here. Sorry, Kate, carry on.
Okay, I'm going to start from the beginning. I was only one sentence in. Okay.
Just move the mic a bit closer to you because it's great acoustics.
Is that better?
That's better.
Okay. Last summer, the CCG ran a listening exercise for proposals for a new health and wellbeing hub in Shrewsbury, which potentially involved the closure of some of up to 8 GP practices in South Shrewsbury. The first that residents and councillors heard about these plans was via an article in the Shropshire Star. This significant potential change in service provision understandably caused concern for residents, particularly regarding travel and access issues. As a result of residents' concerns, Shrewsbury Town Council invited the CCG to a meeting in January 2022, at which a CCG representative acknowledged that the consultation last year was not good enough, and they also asserted that there were no clear plans for how the new hub would work. They informed the meeting that a future consultation would shape the design of the Health and Wellbeing Hub were it to go ahead. In April 2022, the CCG announced more detailed plans for the Health and Wellbeing Hub, including the closure of 6 surgeries and a likely location in Meal Grace. It would appear that the plans for the Health and Wellbeing Hub are well developed and are being brought for the first time to the Health and Adult Social Care Scrutiny Committee on the 16th of May 2022, today. Has Shropshire Council been approached by the CCG to discuss these proposals prior to this? And if it has, which departments were approached and when were they approached?
Thank you, Kate. And I think we've got a response which Daniel's going to narrate.
The response to follow Daniel Webb, Overview and Scrutiny Officer. The response is as follows. Thank you for your question. From a Shropshire Council perspective, in January 2021, the leader and chief executive were asked to give their commitment to work with partners as a stakeholder in this project, led by the Clinical Commissioning Group, in recognising the potential opportunities and challenges this proposed model and NHS investment in community and primary health care and wellbeing services in Shrewsbury could bring to local communities. This work initially involved supporting requests to identify potential areas of land suitable for the proposed hub. In September 2021, reference to the Shrewsbury Health and Wellbeing Hub was included as part of the regular integrated care system update to the Health and Wellbeing Board for the first time. At this point, the work had begun to move to listening and engagement exercises led by the Clinical Commissioning Group. At this board, the Director of Public Health asked that a full integrated impact assessment be carried out, and members of the board also asked that it come to Health Overview and Scrutiny Committee. Today is the first opportunity for this to be brought to scrutiny due to delays through Omicron and the timing and agenda of committees. An integrated impact assessment will consider impact and risks associated with a change in location of services, such as impacts on transport, deprivation, social needs, and impact and risks to those with protected characteristics, and what can be done to mitigate any perceived negative impacts. It is council officers' understanding that no new practices will, it is council officers' understanding that no practices will close as a result of this work, rather practices will move to coalesce in a new building. It is also our understanding that work is underway with partners to consider wider services such as diagnostic services, which will bring additional services into the community. We can confirm that Shropshire Council officers have also been invited to attend the Shrewsbury Health and Wellbeing Hub meetings, along with other partners as key stakeholders. This has been prior to the meeting today. As stated previously, initially, one of the public estate team were approached by the Clinical Commissioning Group and have attended meetings regarding estate issues. Latterly, following the Health and Wellbeing Board, both the Public Health and Insights and Engagement team have also been approached regarding potential council and wellbeing services that could be provided from a hub model, engagement with partners, and to revise on the requested impact assessment. Thank you.
Thank you, Daniel.
Thank you. Can I have a follow-on question to that?
Can we wrap it into because we've got the Health and Wellbeing Hub as the next item. Do you want to wrap it into that rather than, because we've got people waiting? I'm easy. But...
Yeah, I'd probably rather.
Okay, go on.
Yeah. I'm just, I guess I'm wondering why counsellors weren't invited to be part of this consultation. I mean, I think the meeting will show that the listening exercises so far haven't gone down so well with the public. And as counsellors, particularly perhaps the counsellors in the local wards where the surgeries are possibly moving, could have been involved in some of these discussions. I mean, I personally found out in the Shropshire Star, so I'm just wondering why councillors weren't informed, as there's clearly been some debate going on for a while.
Yeah, I'm not sure that's anything I can answer, but you know, hence Rachel, middle one.
Apologies. Yeah, so just Rachel Robinson, Director for Health, Wellbeing and Prevention, Executive Director for Health, Wellbeing and Prevention. I guess some of those questions I think we need to round up in the next item, I guess, and that we need to explore fully. I think, so obviously we've mentioned that it did come to the public meeting in terms of the Health and Wellbeing Board, which was the first time that it came through to public. And I know there has been engagement and stakeholder activity after September, and some involvement from local councillors and members. So I think this is a question that we need to probably go through with the CCG, if that's okay, once we go through the substantive item, because they're going to take us through a timeline to understand the kind of process that's been gone through. So if that's okay, that we can reserve that question.
Okay. You say they're not online yet? I can't see who's. Should we move on to Bishop's Castle first then? Do we want to move on to Bishop's Castle first? Oh, we have to twiddle our thumbs for a little while then. While we wait for people to drop in, do we want to do a work programme then, Daniel? Put you under pressure while you're typing.
if in future we're going to do this and everybody else who's presenting is online, do you think we could have at least one person here from whichever group? Everybody else could be online, and one person in public would be really good, because then we don't have to do this and waste the time. And it is really important that we do these things properly and we don't end up rushing them. So if we could request that in future, I'd be really grateful, and I'm sure the committee would be too.
We can certainly try. Whether we succeed or not is another matter, but we'll ask.
I think it's more than asking, it's actually requiring.
Never seen anyone type so quickly. Work program. Okay. Yep. Reflection this side. One. Ah. Anybody else?
I think I've made a wait for Rachel.
Just waiting for Rachel to come on, is it? I can't see who's on the screen on the side.
Morning.
Good morning.
Good morning.
We can. Everything's working. So, we've got Edna.
Yes, morning.
So, welcome to the meeting. I think we've waited for Rachel to join in.
Right, which Rachel we talking? Rachel Robinson or?
Rachel Jones.
Oh no, Rachel's not joining the meeting. It's just myself and Claire Parker.
Okay. So we've reached your agenda item. So I don't know if you've got a presentation or what the plan is, but
I do. I do. Can someone give me permission to share my screen, please?
let me turn that up. We're just going to try and play with the IT so we can hear you better.
Okay.
We apologise, but we're in a new room today and we are not connected to speakers.
No worries. Apologies. I thought I was on at 10:15, and then got some urgent text. You're needed now. So apologies for lateness.
That sounds louder.
Okay, can everyone see that?
That's better. And we
Okay.
can hear you as well.
There is a bit of an echo. Yeah, I think you're doing the first few slides up to roadmap. Can you hear us now? Is that okay? Can you hear us? Can you hear me? Hello? Can you? I don't think they can you hear me? No, I don't think they can.
Okay, try again.
Okay, I can hear you. Can you hear me?
That's better. Okay. We've got a presentation in front of us now.
Okay, good. So I'll let Claire kick off. If you just want to tell me to go to the next slide when you need to.
Yeah, thank you. Apologies, I have got a bit of a cold, so I'm hoping my voice will last long enough. Good morning to members of Health Overview and Scrutiny panel. I'm Claire Parker, I'm Director of Partnerships for Shropshire, Health and Wellbeing and CCG. We just thought it was worth just doing a quick background as to why we got to where we had. I think in the same week that I was approached by 3 of our practices about lease issues and capacity issues around building in estates, we were also approached by NHS England with an offer to run a pilot for a new type of model that had been tried elsewhere in the country, that was a system-owned building that enabled more flexibility to deliver services from a health and wellbeing type model. Because we've got practices in various states of condition that we couldn't expand, and we thought it was worth pursuing looking at the pilot opportunities. And we talked to 8 of the practices at Shrewsbury to see whether they'd be interested in either relocating or delivering wider services, and then what that project would look like. Unfortunately, during that project, we also had to deal with COVID booster campaigns and then Omicron. So things have kind of rather been delayed, and so was our communication. And I talked to the town council back in January and apologised for the listening exercise, that we could have done a lot better in trying to shape what the services would be looking like. But it was really to try and look at general practice and primary care services to improve and expand what we'd already got, because actually we're delivering wider services in primary care, and we needed to look at a better model of integrating prevention, health and wellbeing and community services together. Edna, would you like to move on to the next slide, please? We're working within a really challenged system, as we know. We need to think about primary care as the first port of call, but we also need to look at integrating more preventative services. And we needed to engage with the public on what the potential opportunities could look like. We definitely struggle with workforce. We have a number of practices, particularly in this project, that are struggling to recruit GPs as partners, salaried GPs, and even employ locums. So we know that we need to do something with a multidisciplinary team that looks very, very different. We want to be able to retain staff that come and work in Shropshire, and we want to give them the best possible clinical surroundings to be able to offer a professional clinical preventative service to keep our populations well, improve access, and to do care closer to home. The Health and Wellbeing Hub is still a hypothesis. We haven't formed an idea. We are trying to get pilot designs together, but we really do need the views of the community. And I thought it was worth just going through a few myth busters. If we could just move to the next slide, please, Edna. We are not closing any GP practices by building this hub. They will be relocated into the new hub. Only 6 of the 8 practices have been expressed an interest to relocate, not 8. So that's 6 of them. We are not closing any practices at all. It is a pilot programme, which means that we are having substantial investment given to us by NHS England to work through this potential build. And there are examples across the country where this has been tried before. But under this current pilot, we are one of the largest pilot sites in the country. We're not reducing any services. In fact, we want to expand services and integrate them further. So looking at things like diagnostics from within the hub. And we absolutely have not agreed a location yet. The South Shrewsbury Meal Brace area is where we are looking, but a site has not been identified for a number of reasons. We need to engage much more with patients and the public in shaping the proposals, and we've got further work to do around that, and Edna will talk about the plans going forward. And we really want to understand what is and isn't important to our patients. I think I've just talked about the practices that are involved. Those practices, if we don't relocate them to the hub, there are potential consequences of mergers and closures if we don't do something different. So that is a real risk for us that we are looking at. So I think I can hand over to Edna now for the rest of the presentation.
Oh, thank you, Claire. I was on mute for a moment. So I thought it'd be worth, first of all, just taking you briefly through the engagement roadmap, which just provides a quick overview of how we plan to engage, involve and enable people to have an input to designing what the hub looks like, the services that are delivered within the hub. So you'll see here, and this is a bit of a complicated roadmap, so I can send the charts out after the meeting, but you will see that there is a process that we are taking in line with any type of new service development, which starts with articulating the case for change, engagement with stakeholders, looking at the various options that people put forward and suggestions and potential options that people think could be the solution to deliver what we need with regards to primary care, and all of that kind of culminates in a where we consult the public, which we're hoping to do at some point around October. But it is worth saying that formal consultations, in some ways, for me, isn't always the important bit. For me, what we need to do is ensure that we have a process of engaging and involving the public as we design what the hub looks like and as we design what the services look like in the hub. The formal consultation will again be about asking them to how can we improve some of our plans, but we have a robust programme, which I will go talk you through in a moment, which tries to ensure that as many people as possible have an opportunity to input to our plans and improve our plans. And you'll see here the red stars. For me, an integrated impact assessment or a quality impact assessments are a key element of any service redesign programme or any news programme. My background is in public health, and I've done a lot around how do we reduce inequality, ensure that we're not inadvertently increasing inequalities by implementing new services. So we've done our initial equality impact assessment, and throughout the process we intend to develop our integrated impact assessment and ensure that that is backed up by engagement to look at any things that we are doing or any unintended consequences or any negative impacts. We do as much as we can to try and mitigate some of those impacts, or at the very least we are aware of some of those impacts. Okay, just very briefly, because I know that people will have lots of questions, so I don't want to spend too much time on taking you through the slides, but I guess I just wanted to first of all put up the slide around what we've done previously and what we are planning to do. So Claire's already touched on the point that we recognised that we held a listening exercise back in August, September, where we felt that, if I'm totally honest, it wasn't so much us listening, it was more of a one-way communication with us telling people about our plan or what we're thinking about doing, without actually articulating the case for change, the reasons why some of these changes need to happen. As Claire has already mentioned, some of the real issues we're having in primary care, which means that if we don't do something, so the do nothing option just isn't an option, because we have a number of practices that saying that without something different, they cannot sustain the current model. So I think we should have started with having those more open conversations with people. But actually what we are doing now is taking a few steps back and actually talking more about the case for change, trying to understand a little bit more about the challenges that people have in primary care, what can we do to improve those, and then talking to them about, if we were going to implement this hub, what could that look like? What services do you think would be beneficial for you to be in this hub? What do you need in this hub to improve your health and well-being, and what can we do to mitigate any sort of negative impacts that might occur from co-locating a number of practices? So throughout the month of May, we are running a number of focus groups, both face-to-face and online. There was a bit of a feedback. I don't know if that was just me that heard that. Shall I just carry on and ignore that? Shall I? I'll carry on. Sorry. Some of the key things that did come through from the listening exercise and what people told us, and we did get a good level of response. We got over 1,000 people, almost 1,300 people that took part in or filled out an online questionnaire. And some of the things were as expected. People are saying they wanted better quality of care, they wanted good access, they wanted to be able to book appointments more easily with shorter waiting times, all of those things. So all of the things that people have already told us through the listening exercise, and I think we've published the results of that listening exercise and some of the key themes, that is something that we are ensuring that feeds into when we are looking at the model of care and how we implement the hub. So we have taken that on board and we're looking at how we can incorporate that into the hub. I'll skip past this because I've said this, but essentially this just lays out the level of activity that we're doing through phase 2. And an important element of the next phase of engagement also is a stakeholder reference group. So we recognise that we haven't maybe engaged with some of our key stakeholders as well as we would like to, and as well as we should have done. So we are setting up a stakeholder reference group where we've invited a number of our colleagues to be part of that reference group and help. And the point of that reference group essentially is to support us with developing or delivering the engagement and involvement part of this exercise in a way that people believe is open and transparent, and actually ensures that we engage and we talk to as many patients as possible, and we ensure that we talk to diverse communities. So that is still an offer that is out there, that we are about to establish this reference group, this steering group, and we would like some representatives from the council to be a part of that, to ensure that, let's just say, you keep us on the straight and narrow, because we honestly do want to deliver this the engagement part of this programme in the best way possible, but we also want to ensure that we have a mechanism for feeding back the plans in a timely manner as and when we get to that point. I've mentioned the quality impact assessment that we've already undertaken. We plan to continue updating and refreshing the quality impact assessment and the integrated impact assessment as we know more. So once we know what the location of the hub is going to be, we would do a travel and access analysis to understand how that's going to be impacting the current patients and future patients. One thing that's quite important, when I mentioned that we got some feedback in terms of the listening exercise and what people suggested to us we could do going forward. Now, there'll be no surprise to you that there was four key options, or four potential options, that were highlighted through the listening exercise. Clearly, there were some people that said do nothing. We don't want things to change. Some people had said, why don't you do the minimum, which is expand what is the current practices and the current surgeries, or build temporary buildings to enable more patients to be able to access. Some people said, why don't you build 6 or 7 new practices? And then there was the final option, which is build the integrated hub. Now, as you can appreciate, not all of those options are viable, but we are ensuring that instead of just saying, no, we can't do those options, we are looking at a robust evaluation criteria and methodology to ensure that we assess all of those options against some criteria. Some of the criteria that we've got has been set by NHS England, so that includes what are we doing to improve access and patient choice? Are the plans fit for purpose? Are the plans financially viable, and do you have the workforce to be able to deliver any of those potential options? So those are some of the criteria that we plan to mark some of those, or assess some of those options against. The other thing that we are planning to do through the next phase is ensure that we develop other criteria. So some of that criteria that is shall I say, we can't influence, because NHS England tell us that we need to, any service change and any options needs to be marked against those criteria. We also recognise that there are things that are more important to people and to patients. So part of the next phase is actually finding out from our patients, what other criteria should we be evaluating some of these potential options by. Now, this sounds like a complicated process, but actually it's quite straightforward, and it's a process that we often take when we are looking at designing any new services. So we intend to go out to consultation, or to consult people on whatever is the viable option or options in October, and we intend to run an 8 to 12 weeks consultation in that period, and we will come back to this to scrutiny when we have more firmed up consultation plans and engagement plans for further scrutiny. That's it. Apologies, I know that we've got some technical issues. I hope you could hear me, and I also appreciate that was quite a lot to go through, but I hope that you got the bulk of what we were saying and proposing today.
Yeah, thank you, Randy. That's a lot of information to take in there. It's obvious that you are right at the start of this process, so there's a lot of work ahead of you, but I'm sure the members have lots of questions. So I can move it on first. We'll start with Kate.
Thank you, Chair, and thanks for the presentations. There's some new information in there for me, so that's been helpful. So I'm Kate Halliday, I am Counsellor for the Board. Obviously, I welcome investment in our services in Shrewsbury and Shropshire, and certainly I welcome improvement of care. I have to say that this is a really massive issue for residents. I've had a lot of emails, I've had a lot of contact. I was invited to the Bellevue Knit and Natter group last Friday, which I attended. They wanted me to come specifically to talk about this issue. Over 20 women in the older age group demographic. And I just want to feedback what people have been saying to me, which is, just to remind you that there are 2 surgeries in Bellevue Ward who are identified to relocate. Can I just ask just one question? When you say they're relocating, are they going to retain their GP partnership structure, or will they be salaried GPs in the new structure?
They will retain their existing practices in the new building, so they will retain their GP partnership structure. They're not changing in that way. They will retain their existing contracts.
Okay, thank you. That's helpful. This is what residents are saying. They are really probably top of the list of concerns is travel. They're really worried about travel. I understand they're saying they might not be meal breaks, but that is the location you've identified in the document, so that is what everyone is focusing on. Most of them are currently able to walk to see a GP, you know, a few minutes walk. Many don't have cars. To access the surgery and the embrace, this would be too far for most of them to walk. Especially they say they're feeling unwell, and they would have to rely either on a bus. Now, it's difficult to know where this is going to be, but people are worried about whether they maybe have to take 1 or 2 buses, and that's certainly going to be the case with people in other areas. They are worried about the bus service itself. They're currently being cut and reduced, and they have not been that reliable lately. They're worried about the cost of buses, and you know, the cost of living. That's a real issue. They are worried that they're worried then if buses aren't available, taxi. They're going to have to start making taxis to visit GP surgeries where they weren't having to pay before, so they're worried about the cost there. They are worried about, as well, I mean, certainly somebody who cycles, the Neil is not a nice place to get around by bike, and also people with mobility scooters also especially are concerns about their access to that area. And really what they were saying was largely that they worry that if they were feeling a bit unwell, they probably would be put off attending GP. And I think the whole point about health quality is preventative medicines and catching things early. So that's one concern. For those with cars, they're worried about congestion, cost of petrol, parking. With so many patients, will the roads and this new surgery be able to cope? We've already had, cars travelling past the Meal, Brace and Priory schools. There's already been accidents there with school children. There's lots of local campaigns on road safety, so there's a lot of worry about congestion. There's a lot of concerns really about carbon in general, carbon emissions. I know that the building sounds like it's good in terms of carbon emissions, but new builds do have an impact on carbon emissions, and all that travel will have an impact on carbon emissions as well. It's going to increase the number of car journeys in Shrewsbury, and we're actually really trying to do the opposite at the moment. We're trying to reduce car journeys. What will happen to the old surgeries? Will they be knocked down and turned into new buildings? That's got a carbon impact as well. So I've had a lot of comments from people who are concerned about that. I did actually go on and try and discuss the positives of this proposal. I didn't go in with a view on it at all, and I did talk about the positives. I talked about meeting the needs of increasing population. Bellevue had very limited development opportunities, so I'm not sure how well that went down there, but there are large developments in Huntley Road, Weir Hill, Roebuck areas of town. But most areas respond to large new developments by creating new GP surgeries, and I'll give the example of Lawley Village over in Telford. You know, their GP surgery turned up long before the development started, and so lots of people were asking, like people in your listening exercise, about why we can't build a few new GP surgeries where they're needed. So residents are confused about the need for this new building. I mean, one of the surgeries in my ward is around, I think, probably 15 years old. The other is certainly, I think was built in the 1980s, and it's just not sustainable to be knocking down buildings that are relatively new and looking at them. I think there's only one building that is really quite old in the list of 6. So I've got a few questions here. There is a feeling that this is a done deal. It's good for you to hear that you're saying that it isn't, because that is the feeling out there at the moment. So I've got a few questions here. Will the consultation include the options for new GP surgeries? I think it sounds like you're at least going to have them to the list. What is the size of the proposed patient list? It sounds like it's going to be a massive surgery. It sounds like you've done a carbon and impact. We've talked about travel, so I'm not going to talk about that. But my other question is, why have you not involved the counsellors in the wards that you are proposing these changes to? Because and the reason I say that is because I think if there is investment, I want there to be investment. I want improvement in these services. But this hasn't gone well so far. You know, a lot of residents are scared and angry. And if you could involve the local councillors and the wards involved, perhaps this consultation might have gone better so far.
Yeah, I can pick up a few of those points, and then I will hand over to Claire to pick up some of the more technical points, if that's okay. So a couple of things. Partly, I think the reason why there's so much anxiety amongst the general public and communities and patients is because of some of the inaccurate headlines, if I'm totally honest, where we've talked about GPs closing. Now, clearly, if people read those headlines that their GPs are their surgeries are going to close, then that will raise some anxieties, and it will cause unnecessarily people to panic, and therefore sometimes maybe not taking the facts when you are trying to put those facts out. So that's the first thing. I think the inaccurate headlines have contributed towards that. With regards to some of the investment into the local areas, the money that we are getting for this hub is very specific. It's a national pilot, and it has to be used in a particular way. So it can't be used to invest in a number of or investing in a number of the individual practices, because that's not the way that the money can be used. It has to be used to develop a health and wellbeing hub, because that's the national pilot, and there is evidence about the benefits of building such things in local areas. So we won't be able to consult. The consultation will not include the option to build a number of new practices, because part of the rules around consultation is that you can only put out things to consultation which are financially viable, which are viable from a finance point of view, from a workforce point of view, etc., etc. And those options to build a number of new surgeries are not viable options. So you can't consult on options that you cannot deliver. So that's the honest answer around will they be included in the consultation? Probably not, because then they're just not viable under this particular scheme. I'll hand over to Claire to answer some of the other questions around involvement of counsellors and some of the more technical bits.
Yeah, I've written, I think I just have to apologise for not involving counsellors, and actually it feels like it's been going on a long time, because we've just had to stop tools down to manage things like COVID vaccinations, you know, including me. I'm clinical, so I've actually had to sort of stop for a period over Christmas to go and support the booster vaccination campaign. And then we've had urgent care, so that's why things have probably felt a long time, and I can only apologise for not involving counsellors at an earlier stage, but the intention will be to involve you going forward. And I think you're absolutely right. I think hindsight's a wonderful thing. I think if we had involved you, we could have told this more kind of positive story going forward. Just to pick up a few of the technical things. So Edna's absolutely right. Excuse me. We can't use the money for the pilot. We have to draw down different capital for the different surgeries. And where that might be possible for one of the surgeries, it would not be possible for all of them. The reason being that we have looked previously at whether we could expand on the sites. And that isn't always possible, and it is very technical. The GMS contract, the primary care contracts that the practices hold, is very restrictive in the way that they can use those buildings, and actually we want to expand that and to make it less restrictive. So there's a lot of technicalities around the sort of the contractual payments and how we do that, and this hub does give us an opportunity to use the site as a system and not restrict it to the contract space. So for example, a practice could not allow the local authority to use its contracted space within a building. It's not as flexible as that, whereas this hub would enable us to do that. Just to clarify the patient list issue, 6 practices with 6 separate patient lists will be moving in. It's not one super practice. It is not one patient list. It will be 6 separate patient lists. They will just be co-locating in one building. How they choose to use things like reception areas and so on and so forth is yet to be determined, and for the practices to determine as independent contractors. Why have we not looked at one big practice with a new practice, sorry, with the expanding building of housing and developments, etc.? We simply don't have the GP workforce. There are specific calculations that we do to develop whether we need additional primary care services, but we do not have the workforce, and at the moment it doesn't indicate that we would need a new practice. We need to stabilise the existing practices and use those to develop our patient lists rather than trying to establish a new practice, because we just don't have the GPs to deliver that. So those are some of the things, and hopefully some of those things will come out from our further engagement with the public as well. It's a two-way dialogue, and that will be helpful then in feeding into the final plans as we move forward.
Thank you. And just a clarification, so the investment is in the buildings and perhaps the diagnostic equipment. It's not in the primary care workforce, because that's another thing that people are saying. This is just a way of cutting the workforce, and that the GP surgeries will be sacrificed for
No.
exciting.
No.
But will there be investment in the actual workforce, or is the investment all in the build? It's all about the building and the machinery, basically.
No, the investment is in the building. The machinery would be separate. It's not part of that funding. It's about development of the building. The idea of having the building and creating a better model of delivering care is to expand the workforce. By having multidisciplinary teams, by having good modern facilities, that is what enables you to retain workforce. We've got really good training, but it's really challenging to retain GPs. So, for example, one of our practices cannot get partners because the lease is about to run out, and that is one of the surgeries that is involved in the pilot. If we can't renew the lease, then the practice would go. So by having a system-owned building that practice could move into, they will be able to retain staff and expand their workforce. And that's what we want to do. We want to encourage all professionals. In fact, primary care is growing hugely because we're adding additional roles all the time with additional workforce investment, and we struggle in Shropshire to spend all that money to recruit and retain physios, clinical pharmacists, primary care mental health workers, nurse associates, physicians assistants. We have the opportunity to house all of that expanded workforce and increase the number of GPs. I need to be really clear on that. This is about expansion and investment into primary and community care, and not a reduction, and absolutely not cost cutting at all.
Yes, I think that's a point to reiterate and also ensure it's minuted. This isn't a cost cutting or cost saving exercise. We have a workforce shortage, a GP workforce shortage, and it's a national shortage across the country. But in some areas, including ours, we suffer more in attracting and retaining workforce. And so one of the solutions, or one of the things that we can try and do to enable us to attract and retain workforce and people, is to give them the working environment and conditions that will actually attract good people, so they are more likely to want to come and work and stay and working with us if they are in a modern building delivering services in a way that is in line with the national direction of travel for primary care, being in multidisciplinary teams, etc., etc. Unfortunately, we just don't, even if we had the money to build 7 new practices and we had the land to develop 7 new practices, we don't have the workforce to serve them. And that is the reality of the situation. And we would love to have more GPs and more clinical staff, but we just don't. So we're trying to do everything we can to attract and keep those people.
Okay, thank you. And Nick was next, Ms. Parsons.
I'm not sure it is.
Yeah, you're on.
Yeah, thank you. I'm just wondering if we could explore a little bit more how 6 groups of partners are going to operate simultaneously, independently, but also together. I mean, I think I just get the feeling that we're being reassured that nothing is closing, nothing is changing, but at the same time, things have got to change because, it's not working at the moment. I mean, you guys know far better than I do, of course, but my understanding is that the reason why we're short of GPs is hugely complicated. The GP contract is, I think, a big issue. Now, that's not going to change by putting them all together in one building. GPs who'd rather work 3 days a week, why are they suddenly going to want to work 5 days a week? GPs who like working for Shropshire, as well as being a salaried GP, and we all know people who do that, and that's up to them. I'm not saying they're wrong, but why are they suddenly going to want to work full time? I don't see the connection between having a nice building, and I mean that could be attractive, I accept that, and people wanting to work full time, and additional people wanting to come and work, especially if you've still got 6 groups of partners. I mean, you'd have 25 people. I mean, I have no idea how many partners there are in various practices, but say you've got 2 or 3 partners in each practice, that's nearly 20 people. And what is the relationship going to be between those partners, because you've told us that's not going to change, and the landlord? Now, this document that we were sent, is insistent that, I'm not quite sure who, but somebody is going to be the landlord, and the landlord will presumably have a lot of influence and so on over who has which rooms and all that sort of thing. GPs, without being in any sense pejorative, are pretty fiercely independent in my experience. They like to run things the way they want to. They are not, but the partners anyway, are not directly employed by the NHS. They want to keep it that way. They like the freedom that a partnership gives. And you're saying that's all going to work. I mean, I know you've tried this in the London Borough, and it'd be interesting to know how that works there. But dare I say, 2 or 3 London boroughs are a bit different from Shrewsbury, and I think the assumption that somehow you can transplant what works in Harrow and Havering and that kind of thing and plonk it down in Shrewsbury is is courting disaster. I think, you know, if I could just have some reassurance on how it works in practice with, as I say, 6 groups of partners who may get on incredibly well, but maybe they won't. And when, if you shove them all in the same building, you know, if somebody wants to expand, how does that work? Who makes the decision about, you know, one group practice wants to take on an extra bunch of people, and the neighbour also wants the same space? Who makes those decisions? Who actually runs the building?
I can probably pick some of those up, but some of it we won't know yet as we're working through the modelling. So the system owns the building. There's not a private landlord. So and that's the new concept of this. How that works in practice, I'm not the technical expert on it, so I'm not even going to try and answer it, because I would possibly tell you something wrong, and I don't want to do that. But it is a system-owned building, so it's owned by us, all the partners and stakeholders jointly. How that technically works, I've no idea. There will be 6 independent contractor practices in that building, and how they expand and encourage their partners to come and work will be up to them individually. They already work together as primary care networks anyway, and all of those practices are in the same primary care network, so they're already used to delivering services together and working together. I've worked with GPs long enough to know that there are always good and not so good challenges within individual practices, as there should be, and across the practices, and actually that makes for really good innovation and better working practices. How that will work, again, we don't know yet. We've got to work through what that looks like, but again, that gives us the flexibility. And can I just say, if only we had two to three partners in each of those practices, that would be fantastic, but we don't. We have some practices where there is only one partner, and again, it's things like lease extension, challenges in workforce, space to put additional roles and multidisciplinary teams that put GP partners off getting involved in practices. And by starting to develop a different clinical model, flexibility around the workforce, that is what we're hoping will start to encourage GPs to come and work for us. I'm not going to say it's going to change overnight, and I haven't got all the answers now, but we've got to start and do something that looks different. So that's probably as much as I can probably say about that at the moment.
Yeah, and I think Claire's right in saying that we don't have all the answers, and I think you made a good you raised a good example about an example in London, but just to assure you, there are a number of examples across the country that are doing who have already done this or are going to be doing this. So what part of the process is about looking at some of those other examples and trying to understand and learning the best practice, because you're right, I don't think that we've ever said that nothing will change, because actually things need to change, because the way that we're operating at the moment isn't fit for purpose, and it isn't what's best for our patients, etc. So I think that we've been clear that there will be some change, and there needs to be some change, but hopefully the change will be positive, but we are still looking at how best do we need to deliver this, what will this mean in practice, and we haven't got all the answers because we haven't done it yet, but we will be drawing on other examples across the country to help us when we are shaping these plans. But so I think it's a very good challenge to us, how will this work? And actually that's one of the reasons why we want to do more engagement with our counsellors and people at the heart of our communities, because we want that challenge. We want you to ask us those challenging questions, and what we will endeavour to do is go and find out the answers to them. Even if we don't have the answers now, we hope that your challenge will enable us to actually produce a better product at the end of the day.
Okay, thank you. Okay, I've got Councillor Kidd, Councillor Dakin, and then Councillor Benton.
Thank you. With a number of questions around this. We had a briefing a while ago with Mark Brandreth about some of this. And actually in that briefing, he said that much of the money that would be drawn down was for diagnostic centres for the county. And that accessing other funding for the GP practices was going to be difficult. So, how much of this funding is actually for a diagnostic centre which will serve the county? And how much of it is just for a diagnostic centre, which it does refer to in here on page 16 of the document you sent us, that it will be providing services so that the hospitals aren't used as heavily and so on. If you're looking at doing that, it's quite possible, especially if you're looking at meal as an area, that actually this building will be providing services for other places. And if that is the case, and you are getting county-wide diagnostic funding towards this building, then I would suggest your consultation needs to be bigger than it is at the present time. And what do you mean to do about that? That's my first question around that funding, because I don't understand why Mark Brandreth would have told us that if that wasn't the case.
Can we take each question at a time, just to make sure we don't forget them? I can hand over to Claire for this one, but
I'm sure the chair will let me ask my next question if anyone wants that one. No? Good. Thank you. Go on.
So I'll hand over to Claire for this one. It's not my understanding that the funding for this project is drawn down from funds related to diagnostic centres. I can see Claire shaking her head, but do you want to just confirm that? I don't believe that's the case.
No, it's not. When we're talking about diagnostics, we're not talking about one of the diagnostic centres, because they have to, I mean, Patricia's leading that project and she's just joined the call actually. I don't want to drop her in it though. There's the community diagnostic centres have to meet particular criteria, but we are looking at what diagnostics we can use in, but it's not specifically the national funding around CDCs that is coming down. It is NHSE capital monies that we're using for this, which is also separate to primary care capital money. So we're just looking at what the options are. At the moment, it's not a CDC, that's a different funding.
And I can see Patricia's face has just popped up, so I don't know if Patricia wants to just clarify and add to that.
Yeah, I can see where the confusion is, because it's language, isn't it? You know, we're talking about health and wellbeing hubs and diagnostic hubs, and then people sort of assume it's the same thing. So the community diagnostic hub money is based on a Mike Richards report that was published in October 2020 around the delivery of bigger diagnostic hubs as close to the patient's home and communities as possible, with the view that you separate out emergency from planned diagnostics, with the view that not only is that better from an infection control perspective, but also you can sort of major on and make sure that people are getting their early diagnosis for things like cancer prevention and so on, and it isn't being disturbed by non-elective activity going through. So those community diagnostic hubs, the funding that we've received in what I call the phase one funding, we received, Shropshire, Telford and Wrekin received last year for the first centre that will be developed in the TF1 area of Telford, and that is an STW resource for the population of Shropshire, Telford and Wrekin, not just for Telford. And that will be delivering in the main things like CT scanning, mobile MRI scanning, and a plethora of other sort of scans, including spirometry and so on for that for the wider population. We would like to, and we are going to put in a business case for further community diagnostic hubs in what we would like to think is the southwest of the county and the northeast of the county. being particularly minded that not everybody lives in Shrewsbury. I'm one of them that lives in a rural part of Shropshire, and that we need to connect with our wider community as well. One of the biggest planks of the Mike Richard report was around reduction of health inequalities, and so it's really important that we get the spread of those community diagnostic hubs across our county to make sure that patients have access to them.
Okay, thank you. Does that answer your question, Councillor?
It does and it doesn't, in that actually we were briefed specifically around this. And so I'm awfully pleased to hear that actually the rest of the county will be using this funding in other ways. But it was specific at that meeting, at that briefing, that actually a lot of this building would be drawing down diagnostic money and would not be. Well, that's what we were told. So there is.
I think that's just a bit of a miscommunication, or maybe the language.
No, it wasn't language. It was quite straightforward. But let's leave it there. Okay. We reassured you. Certainly.
Yeah. Good. Well, that's the main thing.
But I will watch that. Right. There are a number of other issues around this. In that, I know you've apologised for not including us, but actually, as a scrutiny committee, we should have been included in much of this much earlier, so that we could actually help you build towards this, rather than being at this stage now. So being late in the day with us just makes us feel as though actually we're not worthwhile, and we're a step forward, along with not just scrutiny, but also those local ward councillors. As Patricia knows, if local ward councillors aren't included, as they weren't with Bishop's Castle Hospital but are now, then actually things become much stickier than they should be. They could be if you included us, because we are community representatives. So, if we move on, I'm interested that this is a pilot programme. It does seem to be all about buildings and not about people. We do, as you have pointed out, have a nationwide problem with all staff, not just the GPs. Actually, we have a staffing issue across the board. Whether it's nurses, whether it's a whole raft of other health workers. A building, unless this has the detail around that building sorted, is not going to encourage people to come to live in Shropshire. The details around a lot of this are so sketchy that I am very concerned. If you have separate practices who are desperate to recruit GPs, they are not going to share staff to be able to cover from one another, because they are separate businesses. So there's a whole piece of work around that. And I would admit that if a GP practice within one building collapses, then actually you've got a ready-made other sector there, but it's still not going to help. A big sparkling building is not going to help you recruit and keep people here unless you've got all those details and those ducks in a row, because it could look like a hodgepodge. So the move on around this and how you sell this, one to the public, but two to the people you want to come and work here, will be absolutely vital. And I would be interested to know how you're going to put some of that in place. And I would agree that we are not living in London, where those boroughs have really good public transport, really good. Shropshire has appalling public transport. And I really want to see the results of your initial equality impact study, please, so that we can actually see those results rather than the verbal communication that you've had today. So if we can have that circulated, I'd be really grateful. I am concerned because I've experienced a merger of GP practices in my division, which was absolutely appalling and still is not working properly. That actually, if you don't find a way of this one working properly, you won't make the savings in staffing that you've suggested in your document. For instance, if you collapse the pharmacy, if you're going to have pharmacy and drugs being given out on site, or some of those other subjects, without proper planning, which is what happened with Worthing and Ponsbury, you have some very, very angry people. The IT systems that the NHS are using at the present time for phones are really not fit for purpose. And already in Shrewsbury, I know that people wait up to 40 minutes on the phone to get through. In my emerged practices, they often don't get through, and there is no answer phone. And ordering prescriptions becomes a very difficult thing. These are all these details that sit under a sparkling new building that actually will make the difference to the patient. This must be patient-centred, not building-centred. So how are we going to shift it away from being building-centred to being patient-centred? And that is a fundamental.
Okay, can I respond to some of that? So I guess I'm going to go back to your first point about the lack of engagement and involvement with, I think Kate made the point previously about the lack of engagement with ward counsellors, which we've acknowledged was poor, and it was a point in time. And it was, if I'm honest, before my time, and that's not to say that I'm not making excuses, but what I can only do now is reassure you that we will do better, and we are already doing better. So we are here. We've reached out to a number of you previously, and we will continue to do that. So I guess my response to that is yes, we recognise it wasn't good enough, but we are going to do more. But we're also here saying, can we have your support with helping to improve our plans, with helping to land this in the right way with patients, because a lot of what you said links together. So there's some elements of this that we really want to work closely with Scrutiny, with ward counsellors, to ensure that we get some of this right, because you're right, we don't have all of the detail because we are still working that up. We are, as I've mentioned, we are going to be looking at best practice and examples from across the country, but actually we also recognise that not one size fits all, and our particular county is different from most places across the country. So we need to make sure that, as you quite rightly said, that what we do is patient focused and is fit for purpose for our local populations. So I suppose the way to do that is by ensuring that we are quite true to our word and ensuring that we are engaging and involving and listening to people all along the way to firm up some of the detail. Some of the issues that you've mentioned, it's difficult to respond to that, how we're going to resolve some of that, but I guess that the only reassurance I can give you is that what we will be doing is looking at how we can, or what solutions we can put in place to resolve some of those issues. Claire might want to pick up on some of the other points that you made.
Yeah, I mean, patient focus for somebody with a clinical background is the first thing anytime. So you can have the biggest, shiniest building, but actually if you're not delivering the patient care and the patient outcomes, it's pointless really. So absolutely take that point on board. And I'd agree with as we're looking at some of the services that go in, but actually even before that, if there are particular issues with your constituents having problems accessing surgeries, please do let me know, because we can look at some of the phone systems, because there are issues with that, and we are looking at in the wider sense to improve access before we have any kind of new building. That will be part of it. IT will be part of it. Prescription ordering, pharmacy, etc. will be part of it, but making sure that we get that right is that goes back to that conversation with the public as well. But anything up until we have a new build, please do get in touch.
And then I then just move on to what are you going to do with the sites of these other buildings? It looks to me from the document that you're shifting the carbon footprint from the NHS, from GP surgeries to residents, because if we're not at all careful, the carbon footprint will increase for our residents. If you look at that, all of those 65,000 people who will be impacted by a move like this. So it'd be really interesting to see that carbon balance, that environmental balance. Yes, you're going to show a new well-insulated, energy-efficient building all in one place, but actually, what are you going to do to the traffic, to the carbon emissions from residents, and the costs to those people during this time? So I'd be really interested to see that study, because I think that's important for our residents. And I would really like you to learn from what's happened at Worthing and Potter's surgeries, because the NHS really does not have a very good record at all of IT systems that work. Thank you.
Okay, good. Joey?
Just a minute, will they look at the balance, please, the environmental balance?
Yeah, that is part of the assessment, and just to be really clear, not all the buildings, there's different ownership on the buildings. A lot of them are private landlord owned, some of them are actually owned by the practices. Don't have the detail of which ones are which, but they're not owned by the CCG. We're not allowed to own capital buildings. But yeah, the environmental factors will certainly be taken into consideration. That's part of the workup, and we'll make sure that it is absolutely in there. And in fact, we'll do that as part of the engagement with yourselves to make sure it's answering the questions that you've got, because I think that would be really helpful. And I probably wouldn't disagree with you on the IT front either.
The environmental aspects, as you mentioned, will be part of the integrated impact assessment, but we've done an initial equality impact assessment, but as you can appreciate, it's limited because we don't know the location as yet. So it won't have all the detail that you require in terms of carbon footprint and the climate, etc. But that will come later on once the plans are further along. So that was what I mentioned early on, that an integrated impact assessment and equality impact assessment is an iterative process, that you do an initial impact assessment and then you refresh it at certain points within the development once you have more information.
And you were going to circulate what you've got, weren't you, for us? Because I asked if you could circulate what you've got. Thank you.
Yeah, I've got a question to start with. Most of them have been answered, actually. They were very good questions that come through from that one. When I first read this, I was quite excited about it. I'm beginning to wonder a little bit now. Would churches having a new surgery, would that possibly be able to have a benefit from this at all? In other words, if we've got a pilot to put extra services into a brand new surgery, could it possibly be thought about for the church as well, which is obviously half the country?
So I can answer that part of the question if that's helpful. I'm assuming you're referring to the Mosque development. Yeah, the Mosque development, which again was a joint project with Shropshire Council. That is NHSE GP capital funding, which is different to this. So the funding mechanism and the capital for the build of Mosque is different. However, the expanded services, because of the new build and some additional capacity, we are able to do some of those expanded services up in Whitchurch. So when the modelling and design of the building, we re-looked at it as part of the Mosque development, so that we could make sure that we could incorporate some of those additional roles, those additional services, and make sure there's space for community services, etc., etc. So the answer is it's different funding, but yes, we are looking at the expanded services. And actually, as we learn from the model for the Health and Wellbeing Hub, we will obviously share that learning across the whole of primary care as well.
Excellent. Thank you very much indeed.
Thank you. Patricia.
Thank you, Chair.
No.
No. Sorry, a little bit further. So I'll be very brief. Basically, all the GPs, I noted you put that the majority of practices associated with this scheme are both growing existing practices. So I'm taking that all the GPs within these 6 practices are on board with the suggestions for this hub. If not, and the majority of their patients didn't want them to move, is what happens then? Can you go forward with 4 GP practices being part of this hub and 2 not? Is there a plan for, I know if that happens, I know in London previously when there was talk about on Council for London East, talking new hospital, there was actually a petition and people marched because they didn't want the 2 GP practices to move to the hospital. Kate alluded it was to do with transport, and the 2 GP practices cannot work together. They've got 2 very strong team, key players there that have never been able to work together. So I know you're saying they're separate, but on that point, is there going to be capacity, because these separate practices are all going to have, I presume, a practice manager. I know at my own practice in London we have 7 GP rooms and 6 clinician rooms. Now, is the capacity going to still be for those practices to retain their individual space? I mean, my fear is, as a clinician myself, if you've got to use shared clinician's room, that is not going to work. I mean, nurses work in completely different ways from other nurses. I mean, yes, we share some skill base, and mostly that would be okay, but we're quite precious about our own clinic rooms. I mean, it's the building big enough to do that. But my main concern is, have you engaged with all GPs and are they all on board?
Yes, we engaged with the practices very early on, and we engaged with 8 of the practices, and 2 of the practices decided they did not wish to relocate, and 6 did.
Can I just come back on that? Is that all the GPs, or generally one the GP lead, because each practice has the GP lead? That's all the GPs?
It's down to the individual practices, but I assume that they will speak. They have partner meetings, and they wouldn't give. They'd have to get their partners to agree if they wanted to do that, because that's based on their business model. So unless all the GP partners agreed, they wouldn't be able to relocate.
Okay.
Sorry, you didn't answer the capacity for all these clinic rooms. So each GP practice would retain their own. So so it's going to be quite a huge hub we're talking about, basically.
So we've modelled based on the practice number and a potential growth in patient numbers as well, so that we can make sure that we have enough capacity going forward, and not just the capacity that's existing at the moment, because that's what the restriction is, that because of the increasing need for primary care populations, long-term conditions, expansion, increasing population, increasing acuity of patients, we've made sure that we are modelling that into the practice build, so that there's increased expansion of clinical space for patients, but it is flexible space. So an individual practice, yes, will have their individual space, but actually if they need additional space, there's flexibility within the building to access that, whether that's for clinic services or prevention services.
Okay, thank you. We've got a cut off in 10 minutes time. We've got a few questions to rattle through. So I've got Roy and Jeff on the committee, and I've got Councillor Benedict back and Health Watch also on the questions. So Roy first.
There seems to be a gap here in communication. Firstly, with not being in communication with the council in the first place, and there seems to be an awful lot of well, we don't know at this stage. We'll investigate that. We'll investigate this. I'm not sure if this presentation is premature, to be quite honest, from what I've heard, because there's so many questions coming out about the project, how it's going to be run, how much the NHS is going to put conditions on it. I'm actually ready to present. Secondly, people like the council, patient groups, Health Watch, and so forth, are you really up to speed with communicating development like this within Shropshire?
and getting the feedback you want, because I don't think you are. You missed out liaising with the councillors really right at the start. And to be quite honest, I would imagine from what's been said, this presentation has come basically because of pressure from the council, having heard via the media that things are going on. This has got to improve, and I hope you've got a good media team, because this is going to backfire on you badly if you don't address that situation. Your communication within the communities with health professionals. I haven't heard anything about patient groups, doctors groups, and so forth. I'm just not confident in the communication capabilities with the media at the moment. Thank you.
Thank you. Thank you for that question. I mean, I like to look at things through a more positive lens and think about and acknowledge what you've said, and we've accepted that the initial communication and engagement wasn't what we would have liked, and particularly wasn't what I would have liked to have been delivered before I came onto the programme. But actually things are different now. We also have to acknowledge that at the start of this pilot, we were really restricted on what we could say, and that wasn't us saying that we didn't want to be open and transparent. If I'm honest, sometimes with these pilots, when it is NHSEI funding, they restrict how much you can say about things and when you can talk about things. So we've had to do a lot of pushing back to say, and rightfully so, we need to communicate and engage better on this, and that's where we are now. So I'm hoping, with your permission, we can try and draw a line under what went before, because I think we've accepted and acknowledged that it wasn't good enough. And actually what we're saying is that moving forward, we're doing everything we can to ensure that that communication and engagement with the council, and more importantly, patients and communities, is better and is done in the right way. And that's not because that's what we have to do. That's because I fundamentally believe, given my background, that actually the way to ensure that we get the best product and the way that we deliver services in the best way is if we are patient focused, and if we co-design things and we work with patients, stakeholders, etc. in delivering, in designing and delivery of new services. I think that you're right you're right to say that there's a lot of unanswered questions, but I guess that's why so I guess we can't have it both ways. We can't say you haven't engaged early enough, and then when we are engaging early and we haven't got all the answers, saying that it was premature to come and talk to you. Because actually why we're here is we're saying that we are in the early stages, so we want to set the record straight and say this isn't a done deal. We aren't doing things behind closed doors and have all the plans and all the proposals written in stone. There are a lot of things that we absolutely acknowledge, and we take on board what you've said today, that we need to go out and need to find out a little bit more, because logistically some of this could be a bit of a nightmare if we don't get it right. And it is our intention to do everything we can to work with you and other colleagues and patients and partners and the practices to ensure that we deliver this in the smoothest way possible. But we're here saying we're open to suggestions, and we're happy to take the challenge and ensure that we do better and improve our plans.
Okay, thank you very much. Jeff.
Thank you very much indeed. And I just would like to say I agree with exactly what's been said. I do think this meeting is a bit premature, and maybe you should hold another meeting to give us answers to the questions we've asked today. One question I have is the criteria. What's being used to determine the preferred location of where these premises should be? We've highlighted the shortage of travel and problems and so on. Should this hub be in the middle, right smack in the middle of the current catchment area of all these surgeries at the moment? And what assessment? There's no impact assessment, you said, available because location has been agreed. Therefore, I think location should be addressed pretty quickly, because people are concerned about this. People have got to travel, they're not very well, transport's not very good, and I think location is of prime importance, and that should be addressed. I would like that to be identified and then put back to us so that we can all agree a sensible position for this hub. Is that possible?
So I'll hand over to Claire to deal with the more technical aspects of the location. I guess from our perspective in terms of what can be influenced, the location is a really tricky one, because as you can appreciate, that location needs to be one that, yes, is accessible, but actually there is some limitations on where potentially we could build this premises. So it isn't necessarily something that we can how should I say, consult on, because there are some very strict rules in terms of where the hub is built, and there are other factors that will influence where the location that we can select. But I think Claire might be able to offer a bit more context around the location.
So how do you identify meal brace then? On what basis? Or is that just a rumour?
Meal brace as in the wider area. It's just it's very dependent on what available land there is, the size of the building, and then there's some technical surveying type things that need to be done to make sure that the land is suitable to build a building on in. I don't have that technical knowledge, unfortunately. We have not secured a suitable site at the moment. We are looking in a general area that is in a reasonable proximity to the practices involved. So it's really hard to talk about it because we just don't know where it's going to be. And actually, one of the confounding factors might be we may not actually be able to find a site to put it on. So we would then have to think again. We're just scoping that at the moment, and it hasn't been confirmed. So it's then really difficult to do the travel evaluations, the parking evaluations, and all of those without knowing where the site is. And certainly the council have been very helpful in helping us look at sites and a part of that project team from an estates perspective.
Is there a funding deadline then to make this decision to find a site or not?
Yeah, there is. I don't know what the deadline is, but there are timelines and deadlines for us to secure the site to enable us to draw down the capital cash from NHS England.
Okay, thank you. That's it from the committee. We'll move over to Councillor Benedict, who is representing me.
Thank you, Mr. Chairman. Yes, I'm one of the councillors in the area that's affected, and I welcome the CCG stroke integrated care systems commitment going forward to involve the council. But I have a number of questions, and my residents are very concerned, and residents in south of Shrewsbury have written to me who are not part of my board with similar concerns. And they are that there doesn't seem to have been very much consultation so far with those people who don't have access to information technology, may not read the Shropshire Star, and so will the CCG stroke LCS give a formal commitment to write to all 45,000 patients of 6 practices concerned about relocation, and additionally to the 22,000 patients of the 2 other practices in South Shrewsbury that are part of this exercise of moving some services to the new health hub? And will there be a footprint left in the areas vacated by these practices for those people who cannot move, who cannot travel to this new hub because they are physically unable to, or there are other reasons that make them unable to? And the third thing is, what will the CCG/ICS do about the pharmacies which are currently in close proximity to the current practices, and which would face closure if the practices move? And additionally, the patients of those 6 surgeries would not be able to attend locally to those pharmacies to obtain prescriptions. Thank you.
So I can answer some of those questions, and I'll pick up and hand over to Claire to answer the rest of them. So in terms of right into the practice, I totally agree with you in terms of things being very digitally led, the way we communicate, and it does exclude some patients, some people. So we are suggesting to we physically cannot write to all the patients because we don't, but from an IG perspective, we don't hold those the data for those patients. So what we have suggested and what we've provided all of our practices with is these toolkits, which has things like example letters and information that they can use to write out to all of their patients. So first of all, so I totally agree, that is a good suggestion, and that is something that we have recommended. There is obviously a cost attached to that, so we are working with those practices to work out the best way to try and get that information out to their patients. So some of them might use text, because a lot of them now text their patients. They might text them and provide them with additional information, or it might be letters. So it's going to be a blend of how we will inform all patients, but we absolutely think that's the right thing to do. In terms of the footprint and the travel, again, that kind of thing we'll need to scope out via the integrated impact assessment. So part of an integrated impact assessment is, once we know the location, we then start looking at we do some travel analysis, and then what we need to do is ensure that we work and engage and involve patients and all different types of communities to look at how we might mitigate any impacts that changing the service might have on them. So we hope we will pick some of that up as when we actually undertake the integrated impact assessment. Claire, you might want to answer the question around pharmacists.
Yeah, we have a duty to engage and consult with pharmacy contractors that may be affected. That does have to be looked at. So that will be part of it. Again, we can't do that until we know where the site is, and we've got other things that are finalised. So once we've done that, then we'd engage with pharmacy contractors.
Mr. Chairman, can I ask a supplementary question? That's really quick. It is. Can I ask the representatives if the CCG/ICS will give a commitment to ensure that phone waits for patients trying to contact their GP surgeries will improve from the current 30 to 40 minutes, and sometimes not at all. That happens at the moment. I would say it's reasonable for practices to answer a telephone within 2 minutes of getting that phone call, and additionally that the emergency referrals are processed within 24 hours, and non-urgent referrals to secondary care services take place within 1 working week. Thank you.
Thank you.
I'll take a question from Health Watch. Final question.
Thank you, Mr. Chairman. Can I take it that, although I'm now segregated officially from the committee, which I appreciate, the reason being, that in future I shall be able to ask questions and make comment? Thank you very much. Can I confess, first of all, I haven't even read the report previously to coming to the meeting today, and I must concede that I'm filled with consternation regarding the criticisms and the concerns that have been expressed today. Literally, that's what we're here for, and what the advantages are so far in centralising. Centralising isn't always beautiful. And when you go back to the public, and don't forget Health Watch are the voice of the public for health and social care services, we listen to what they say like you do, and we haven't heard much from you either about what's going on, and this is the first I've come across it. I am concerned that the broad brush approach will not be taken after the pilot schemes have been completed, because what is possible in places of dense urban areas is certainly not possible in rural areas, because it'll cause so many travelling problems, as Kate has said earlier on. For instance, I live in Ardley, and if you move the surgery there from Ardley, most likely to Bridgeport, everybody's going to go 7 miles, and the public transport, as we all know, is appalling. Now, I'm just wondering too, why the 2 surgeries decided they don't want to join in. I don't know whether it's mentioned in the report, but it interests me, have they got some good reasons why they don't want to turn in? And the other thing that bothers me is how long is this pilot scheme going to take? And it might be in the report, I don't know. And are we going to have interim reports to show us what progress is being made? Because I think it's very important to make sure consultation and communication is really much better than there has been. Thank you.
Did you guys hear that?
Yeah. The first question about commitment to improve response times on the telephone, I guess we can make a commitment to do all we can to try and improve that. And that would entail, again, working with patients to understand what we can do better and working with the practices to look at how we can improve things. So the commitment is there to definitely to try and improve to try and improve those issues. With regards to the second question around communication, I think what we've was that I didn't hear some of that, but was it around better communication again with patients?
A bit more communication with us at Health Watch. We haven't heard much at all.
Equally, except if I have regular meetings with Lynn, and she sits on a number of our communication and engagement meetings where the Shrewsbury Health Hub has been talked about and has been debriefed a number of times. But of course we can improve that, and we can make sure that Health Watch are more involved. I think we've accepted that our general communication and engagement in the early stages could have been better, and there is a commitment to improve that. So of course, and we commit to improve that communication and engagement with Health Watch as well. If you would like me to meet with you personally to brief you on where we're up to, then more than happy to do that.
Thank you. We've got Lynn in the room, so she's got a final comment here.
Thank you very much. And just to introduce myself to the committee, I'm Lynn Corley, I'm Chief Officer for Health Watch Shropshire. This is the first time I've come to this meeting. And I just wanted to clarify that Health Watch were consulted when that very first listening exercise was conducted, and at the time there was a very short turnaround of that piece of work, so it was acknowledged right from the very beginning that further engagement would be required. But one of the things that I did want to point out is that yes, we are involved in that reference group, which I know when that reference group starts again, that hopefully counsellors will be involved in as well. But as Health Watch, we haven't received comments from the public about this hub, and so I would really encourage you, when you are gathering that feedback, to share it with us so that we can see what those concerns are across all of those practices, because at the moment no one is coming to us. People can come to us, we've got our phone number, we've got our free post address, and obviously we've got those digital tools as well. So I would just like to say that we're here to hear these concerns, and we can bring those to the meetings that we attend. But at the moment we haven't been able to do that because people haven't shared them with us. So I just encourage you to get that message out there. Thank you.
Thank you.
Thank you for that offer, Lynn, and we'll of course ensure that we are communicating with the public about how they can engage with Health Watch. We'll commit to do that. Thank you.
Thank you both for bearing with us through technical issues and all the information you've given us. We're going to move on to Bishop Castle now. I think they're staying right now.
Okay.
Right.
Thank you very much.
I think we've done that one pretty thoroughly for today, and they will be returning. So item 7 is Bishop Castle Community Update. But once again, so we're working hard to take that.
I think it's just me. I think I have other colleagues that are probably far more suitable to talk about Bishop's Castle than I am.
So, Chair, shall I introduce the piece? I'm Patricia Davis, the Chief Exec for Shropshire Community NHS Trust, and I can bring in some key colleagues if that's helpful.
Yeah, thank you.
Great, thank you very much for inviting us here this morning to provide an update. And just to give you a bit of background, we are working very closely with the Integrated Care Board and commissioners such as Claire on the wider plans for health across the system, the Shropshire system. We're also likewise working very closely with Shropshire Council. I noticed Tanya's here today and Rachel Robinson on the provision of integrated care across Shropshire, but we have a particular focus working with Shropshire Council at the moment on the model of supported health and care in Bishop's Castle and the southwest area in particular. And that has led to the development of the rapid response team, which is based in Bishop's Castle Hospital. That was started back in January and consists of a team of nurses, therapists, social care workers that reach out into the community and link to community teams. And we'll probably touch on that a little bit later. But you set us 3 questions to answer at this meeting on the ongoing recruitment work, outpatients and what outpatients remain at Bishop's Castle and what have been reintroduced, those services which have been relocated and where they've been relocated. If I could hand over to Claire Hobbs initially to talk about the recruitment piece, because that is the reason why we had to close the hospital, particularly around the lack of registered nurses. So over to you, Claire, who's the Director of Nursing, to talk about recruitment.
Yeah, thank you, Patricia, and morning, everybody. So, yeah, as Patricia said, the reason why the beds at Bishop's Castle Hospital were closed were in response to unsafe staffing levels, and that was particularly around registered nurses. So we're trying all sorts to bring in registered nurses now into the environment, but as you can appreciate, there is a national shortage, so it does continue to be very much a challenge for us. Notwithstanding that, we had a really successful recruitment day on the 7th of April, which was a recruitment day specifically around the southwest of Shropshire. And I just want to note thanks to the local councillors in regards to spreading communications with that, because I'm sure that was part of the reason why it was literally buzzing all day long with people interested in wanting to find out more about working in health services in southwest Shropshire. So it was a great day, actually, and specifically about Bishop's Castle, we managed to recruit 1 nursing associate, 3.4 whole-time equivalent healthcare assistants and 1.4 occupational therapists. Now, occupational therapists are very difficult to get your hands on nowadays as well. There are actually 4 in total, so that means we've managed to supply Ludlow as well with some occupational therapy support. The difficulty was registered nursing. So in regards to what was a really successful day, we did only manage to recruit 0.6 of a whole-time equivalent registered nurse for Bishop's Castle, and only 7.5 of those 22.5 hours were in the form of a substantive staff member. The other 0.4 whole-time equivalent was somebody that wanted to work on bank and support Bishop's Castle. So that still leaves us with a vacancy position of 7.56 whole-time equivalents and only 3.44 in post. So we are really struggling actually to be able to recruit to registered nurses to Bishop's Castle at this point, and there's a long way to go. Notwithstanding that, we are trying all sorts, and I'll talk to you about that in just a moment in regards to what else we're trying to do. Certainly the feedback from registered people and staff that were interested in the recruitment day was that they're looking for portfolio careers, they're looking for new ways of working subacute care. Some were interested in Ludlow rather than Bishop's Castle. There was real excitement about the virtual ward model, which is a fairly new concept for us here in Shropshire, Telford and Wrekin, but definitely one that's going to lift, shall we say. So our plan is to have 249 virtual ward beds across Shropshire, Telford and Wrekin. Hopefully by December 23, definitely by March 24, and that will provide real interest, I think, particularly around registered nurses and therapy staff who will want to have extended skills and work as more autonomous practitioners, which is definitely what we're hearing from potential recruits. So just in regards to what we're doing to try and recruit, so that the recruitment day being such a success, we're having another one in a few weeks' time. That is for the north of the county. However, we do intend to come back to the southwest and make this a continuous cycle of trying to bring talent into the organisation. And so we will be coming back to the South West to do another recruitment day there. There are not just Shropcon recruitment days, so there are system-wide recruitment days as well. There's a further one coming up specifically for the latter part of the second year and third year student nurses that we're looking as a system to try and do a recruitment day for, so that we can offer them what we call golden tickets, so a job in advance of them qualifying, so that when they do qualify they have a set post within the system, just to try and encourage as much new registered nurses into Shropshire, Telford and Wrekin as we can. We're also doing some international recruitment, 12 specifically for Shropshire Community Trust, from a pastoral perspective and a retention perspective. Those international recruits being able to be in a community and feel part of a community is very, very important, and we've heard that strongly from Shrewsbury and Telford hospitals, who have recruited several hundred international recruits. And so there is a question mark in regards to, will that help with the Bishop's Castle perspective, given the challenges around accommodation that we've heard in regards to what might the accommodation look like for groups in the southwest of Shropshire. We're trying to build pipelines of student nurses and student nurse placement. You know, that's our strongest domestic pipeline, and certainly with the inception of 249 virtual ward beds, that will certainly help us to be able to achieve that. We are increasing apprenticeship pipelines in the form of registered nurse degree apprenticeships, trainee nursing associates to nursing associates, and then onwards nursing associates to registered nurses. We have rolling adverts. You'll probably look now and there'll be a Bishop's Castle advert out. Every so often it will drop off and then come back on, and that's because you get further interest and you go back to the top of the search engine in things like NHS jobs when you do that. So if you've looked at times and not seen that we're advertising, there's a very strategic reason why we're doing that. We're trying to develop a Shropshire nurse model, and we're working with Telford College, Shrewsbury College and the University Centre Shrewsbury in regards to that, so trying to grow our own interest for the future. So we're looking at school-aged children as well. We are exploring rotational posts specifically for newly qualified nurses to try and excite their interest in community, rather than thinking that to get true nursing experience and subacute skills and acute skills that they need to go into the acute hospital. It's absolutely not the case, certainly not with us wanting to bring care closer to home, which is what we know most of our patients would want. We're trying to get a bigger social media presence, so we set up from International Nurses Day last Thursday, #ShropcomNurse, that we're trying to sell now, just to get interest locally in regards to working with Shropcom and being a nurse there. And so you can see there's some really great opportunities for us, but none of which are quick wins either. So a lot of these pipelines that we're developing are a couple of years. So there are plans, but nothing specifically that's going to fill that gap quickly for us. I'll pause there.
So in terms of the second question, which is around outpatients that remain or being replaced and those services that have been relocated, Angie, could you just provide the update, please?
Yes, thank you, Patricia. Good morning, all. I'm Angie Wallace. I'm the Chief Operating Officer here at Shropcom. It's just to confirm that we do have physiotherapy continues in the hospital building, along with diabetic eye retinopathy, and I still can't see it, and I've still got to put my teeth in every time I say it. And that is provided by Midlands Partnership, so we provide the facility for them to be there. And as Patricia alluded to, Rapid Response Team are also based in the building, so I'll pause there.
And have any services been relocated elsewhere, Angie? That was another question.
Yes, no, the final question, sorry about that, I forgot to answer that one. The answer is no. All the services that were there prior to October when we closed the inpatient unit have been placed back into the hospital as we stand.
So, Chair, that's our sort of summary and answers to the questions that were posed. I don't know whether you've got any further questions that you'd like to ask us.
Okay, yes, Councillor Heather.
Thank you, and I probably know more about this than you have presented to the committee today, and so does my colleague who's also present. There are a number of issues that actually I think the committee should be aware of, and some follow-ups that I raised with you on Friday. So, I understand that registered nurses are a problem, and they are a problem across Britain, not just across Shropshire. And I'm pleased that the recruitment worked so well, because Ruth, Nigel and I spent a lot of time on Facebook and email actually advertising that, and we did get a lot of people come in. We still need to work on those nurses, and if you remember, I have met on 2 occasions now a registered nurse in Bishop's Castle who during COVID was actually laid off, had her HR letter, would still like to nurse but has never been contacted again, and you, I think, are committed to write to all of those people before they lose their registration. And for this one particular lady, that will be this summer, I think in June. So we need to get a move on with that, and I hope that those letters to anybody who's a registered nurse who has been in the area, because many of these people are people who just want to work in the Bishop's Castle area and don't want to go to Ludlow, so that's another one. If your adverts are popping up on the website from time to time, please tell us, because then we will share those, and if you have found it works very well when we do that. People miss things on the NHS website, and I must say it's very boring. It does not show the glories of working in the Bishop's Castle area and all of its countryside and bonuses of living and working in the area, which we can do across Facebook, and was shared hugely. So please remember us, please keep us in the loop with all of that. We did ask originally, certainly at that first scrutiny meeting, to see a map of the Bishop's Castle patients and how many were actually in other hospitals rather than in Bishop's Castle. I know we've done a lot of work on the postcodes, which are not just Bishop's Castle town postcodes, but that data, I think the committee ought to see how many people in the southwest would use Bishop's Castle Hospital rather than be shunted around to other places, because we all have instances of people from our areas in Whitchurch and so on, and Ludlow and so on. And as we've said several times today, public transport to Shrewsbury is difficult from our area, let alone to anywhere else. So we do want that data, and that would be very good. And we would also like to share some sort of vision, the usage of the hospital, and how you're going to be working with adult social care, please.
Just on the point of data, Chair, I think we have some data, and thank you. Well, firstly, thank you to Heather and Ruth, who've become the new recruitment agents for Shropshire Community NHS Trust. So thank you for your efforts, and it does help actually using the community newsletters, because as Ruth was, as Heather was saying, it does give people a flavour of what it's like to live within Bishop's Castle and the southwest. So it was a good event, I think, because we had so much input from the local community. So just wanted to sort of reiterate the thanks around that. Just in terms of the data, and again, thanks to Heather and Ruth, who've supplied us with other postcodes that helps us to understand the wider geography in terms of representation from Shropshire Council. So we've used that data, and in fact, Angie, can you just give a snapshot of the data of over the last sort of 6 months and the monthly data that we've seen?
Yes, thank you, Patricia. And I also would like to say thank you to Councillor Kidd, Horton and Harling for being our recruitment agents, because it did make such a difference. Just on those notes, you are aware, as we have spoken to the other councillors, that because the numbers are so small, GPDR means I can't release the data in the way that you want it to be released. What I can do is give you high-level aggregated data, because our CIRO in the organisation has identified this is patient identifiable. So from an average perspective, of the postcodes, the 2, 4, 6, 8, 10, 8 to 10 postcodes that you gave us, less than 5 patients per postcode per month would have accessed inpatient unit beds. That means those ones in the Bishop's Castle area. What I have to then say is that those 5 may have also had to go to one of our other hospitals due to the nature of their illness. For instance, they may have been COVID positive, of which then they would have gone to the designated community hospital, which is Whitchurch. So they may therefore not have come across to Bishop's Castle. The other thing that I just need to note is of those patients in that group, roughly, we know 30% are waiting for onward packages of care, and I have to thank to Tanya and her team who are working really closely with us to make sure that we can transition those patients quickly as possible back to their homes for their care or into the appropriate place of care for them. I just want to note as well that during this period, our rapid response team have started to see an increase in activity of caring for people in their own home. So on average, by month, for those people in those postcodes that I've identified, around about 550 patients are looked after in their own homes related to that, from a range of services, such as home physio to integrated therapy to district nursing and so forth. So I just wanted to give you some context in the round. But Heather, thank you for your question, and I'm sorry I can't release the information to you, but that's as close as I can give it to you.
Can I just come back on that? You said 5 patients per postcode. Do you mean all the postcodes or per postcode? Because there were so many postcodes from SY15, 21, 5, 9, 7, 6. Yeah.
All of them, Heather. In some postcodes, in some months, there was 0 activity. So that's where we've got to on some postcodes in some months.
Yes, if I may, Ruth Hampton, Councillor for Bishop's Castle. I'd just like to thank Patricia and the team for the open conversations we've been having online over the last few months with fellow councillors and so forth. But I still have some questions. It's really positive, first of all, with the physio services and eye care services back at Bishop's Castle. But the community will need to know that. So my plea is that there are some communications out locally that state how far the trust has come in revising services within the local area. And I think that's really important because people still ask me, when is it going to be, will there be any beds there? And I do think the community needs to know how successful the recruitment programme was, the position regarding qualified staff, and what services are now back in Bishop's Castle, and that's important. Bishop's Castle Hospital is very well known and well respected for providing really high quality palliative care. And my question on the rapid response team service is whether rapid response are now providing palliative care at home. That's a general question, but also a specific one, having had some inquiries over the weekend from the local family needing that service. It's distressing, well, it's disappointing that we didn't get enough qualified staff applying, and I understand it's because there isn't enough technical and clinical skills involved in the services offered at Bishop's Castle. And linking back to our first discussion this morning regarding the Health Hubs in Shropshire, I'm concerned that any funding will go into those hubs to develop diagnostic services, and there won't be any to develop Health Hub in Bishop's Castle, which is what's needed, so that there are higher skilled jobs that are recruited, so that qualified staff can be recruited. Thank you.
Any responses to that?
Yes, so thank you very much, Ruth. And just in terms of the end-of-life care, yes, all community district nurses, therapists and the rapid response team do provide end-of-life care for patients, and they do that often jointly with social care in terms of providing any sort of domiciliary care that's needed or packages of care for patients too during that short period of time, equipment and so on. So yes, all teams, community teams, are trained as district nurse myself. One of the biggest and most rewarding elements is providing end of life care to patients and their families. So yes, we do that within the community as well. If a patient requires a bed, then we would often work with the hospice to do that, or we utilise our community hospitals for end of life care should that be required also. Just in terms of the other question, Angie, do you want to sort of respond? That would be great, thank you.
Yes, thank you. On the comms, absolutely, we agreed to commit to doing that on Friday. We were just waiting for HOSC to be cited before we released the comms out. So we will be doing that and utilising our councillor colleagues to do that. And just on the point that Councillor Kidd made around the bank nurse element, Claire, I don't know whether you want to come back on that one.
Yeah. I mean, sorry, Claire H. I was just going to say something about Shrewsbury Health and Wellbeing Hub. I'll just grab that bit first. It's a different competency around the workforce element. So the nursing competencies that we'd want when we're looking at workforce going into primary care would be slightly different to those that would be needed through Bishop's Castle. So although we'd be fishing in the nursing pool, we wouldn't be fishing in the same kind of nursing pool. So sorry to jump into that one. Too many Claires.
Yeah, lots at Shropshire as well, Claire. Yeah, just Councillor Kidd, in regards to your comments earlier about the bank nurse situation, yes, I did pick up on that point end of last week, and the people team are working on getting those letters out, so I'm keeping close to that until I know that they've left the building, shall we say. And in particular, the one nurse that you mentioned, whose name I'd managed to chase down, they'll be getting a call this week, and I'll drop you a line to let you know that that's happened so that you're aware. I think you've made a good point as well in regards to the adverts being a little bit dry. And so for me, that will come in regards to the Shropshire nurse work that we're doing at the moment. And then we will definitely be doing some YouTube videos and trying to do something a little bit more exciting around the adverts for sure. And I will certainly make sure you're linked in when we are taking the adverts down and then popping them back up. So thank you for the offer of support once again.
I just might come back very quickly around the qualified, attracting qualified staff to Bishop's Castle. The point is that you can't attract qualified staff to with the same set of skills as a community hospital. But if you need to attract qualified staff, then you have to put some higher level clinical intervention into that centre. My concern remains that there won't be enough funding to do that, given the focus on the Shrewsbury outcomes.
Yeah, so I think there's a valid point, isn't it, about funding and commissioning, and of course I think both yourself, Ruth, and Heather's talked about the importance of developing a vision, and we are working very closely with as part of the integrated care system, but also with commissioners around what that looks like, so that we make sure that we're matching. We can come up with a proposal with our community, wider community, around what we think from a health perspective should be put in there, and we are working very closely with Laura Tyler and Tanya's team around what kind of integrated services are required to meet the population health needs of Bishop's Castle and the South West, not just now, but also the growing and changing population over time, so that we can put a vision together, as you described, to say this is what we feel will be the best services, mix of services in terms of preventative health and social care for people, as well as delivering care when they need it, and working closely with the commissioners that then commission that model. So we need to make sure that we're creating a vision which is realistic and sustainable for the population now and into the future, which is why Claire and Simon Whitehouse in particular is very involved in those discussions.
I think if I could just add, it's potentially an opportunity to do something different that's really focused on patient outcomes as well.
Thank you. Just one query. Previously, registered staff and that have been shared with Bishop's Council. Well, if it tends to be that this could still be a case, because obviously then that leaves Ludlow vulnerable, and both our hospitals are absolutely vital, Ludlow and Bishop's Castle. But I know in the past you have taken some staff from Ludlow to Bishop's Castle to bulk up, nurses, particularly the registered nurses. And just to agree with Ruth on the skill-based stuff, I know lots of newly qualified nurses that just will not come to Ludlow or Bishop's Castle because they see it almost as, it's not my words, but their words, a nursing home. They want to do a little bit more. And Ludlow in particular, I know Bishop's Castle have the capacity and space to do a lot more in that regard. And like Ruth, I would be a little bit concerned that funding is going elsewhere where our community hospitals are absolutely vital, and probably the beds are propping up the acute hospitals, so we need to get them a little bit more upskilled.
Yeah, I completely agree, and I've heard those myself, so it's not new news for sure. I think the inception of the rotational posts will help in regards to skill sets. Certainly the patients that we're seeing in the community hospital beds that we have open currently, since the start of the pandemic, we're seeing higher acuity and dependency for sure, which we hadn't seen previously. And that's the subacute model that we talk about. So by having rotational posts, that will certainly help our staff to develop the skills that they need moving forward. And then you're quite right, in regards to Ludlow supporting Bishop's Castle, that has happened previously and indeed is happening across the three inpatient areas currently, just because of certainly the last couple of months. It's certainly feeling, touch wood, a little bit better at the moment in regards to staff absences are linked to COVID, but certainly over winter months we've been sharing across the three open inpatient areas. The difficulty we've got with trying to do that currently with Ludlow staff going into Bishop's Castle is that there's a 33% vacancy in Ludlow as well, and so we're just about managing to keep those beds buoyant and safe at this point in time. So it is a real challenge for us, hence why we're trying to do focused efforts around recruitment specifically for the southwest of Shropshire.
Sorry, that's someone too, and maybe a little bit concerned you saying that Ludlow is obviously, yes, and to keep their beds viable we need more staff, but I have like a vision of one of these hospitals having to go somewhere because you're not going to get this staff. So what's in place to suddenly we can't leave Ludlow vulnerable because Bishop's Castle needs the staff, and we can't leave Bishop's Castle vulnerable because Ludlow doesn't. It could be in a scenario where you're not going to get enough staff, and I know Ludlow's been the closure of beds over the years, it's got less and less and less, and so as the Ludlow Council now I'm sort of alarm bells are ringing. I'm thinking, it's going to be a scenario where one of these hospitals, however we find, ever finds, I find, Ruth finds it, because one of them is going to become vulnerable, will actually, that'll be cutting. Sorry.
I think just to come back on that, hence why we need to focus on having sort of hubs and the rotation into sort of communities, and certainly on the recruitment day the staff were really clear that came forward, and it was an exciting day, very much told us that they want those portfolio careers. There was a greater interest because Ludlow does provide more subacute care, and actually the team there want to provide more subacute care because it grows their skills and keeps them interested. But that combination of being able to provide subacute care, but also the virtual ward and the providing care in people's homes and the complexity around that, I think is what makes things more attractive. So by being flexible and having a flexible approach to that, I think is more encouraging. So I think you're right in terms of somebody coming out that's newly qualified and going to Bishop's Castle into a hospital environment which is really providing sort of lower grade rehabilitation isn't as attractive for somebody that wants to develop their IV therapy skills cannulation and subacute skills, as well as provide end-of-life support and so on. So I think we have to be cognizant and real about that in terms of how we can provide an exciting hub model that also allows people to do outreach into places like Bishop's Castle and deliver exciting services as well that keep people at home. The encouraging thing around the rapid response team, certainly within Bishop's Castle and recruiting to that, has been quite successful because teams have seen that as a real opportunity of building their skills. And if you look at just the numbers and the throughput per month going through that rapid response team is phenomenal. Again, they link into our substantive community teams that also want to be part of that upskilling. So I think there are opportunities for us there that clearly new staff that are interested, that have come forward, are telling us, as well as what the data and the information is telling us. So I think there's a vibrancy around the southwest, but I think you're right, and Ruth and Heather are right in saying we have to craft out that vision really for people so that they can see that that's something that's very tangible for them to be a part of.
That's really great. I could go beyond that.
I know that you've been doing quite a lot of work about increasing beds and so on, adult social care, which is a real plus, and takes some of the pressure off care packages rather than waiting for them to come forward. And there are all sorts of issues around those. But the community very much would like to see some nursing beds there in whatever form. And I think Ruth and I have made it quite clear that we would like to see those as part of the vision for the future, and that would help nursing staff and so on.
Can I thank all the ladies who's been answering all questions for your input and updates, and that will be coming back to you for a further update in a couple of months' time. So thank you.
Thank you. Thank you for your support too.
Okay, final Daniel, work program.
No work program. We just get the next stage of the next few weeks to set our work program for the year ahead. So I'll arrange that meeting. I've just spoken to arrange that. As soon as I've got that, I'll share that day with you. In my short term, I kind of noticed that the first item we kind of left it as hanging in the air in terms of where you'd like to go next with it. So perhaps we could just take a few minutes to sort of have a think about what it's like next from our partners with regards to the hub.
I think there was mention of a chapter representation on the group, wasn't there? So do we looking there to local members, or what's the I guess the question is, does it need political balance, which I presume it does? So that's correct.
Not for an informal group, no. I think it would be useful to just, because it's but certainly it's not mandatory. But
well, I'm assuming that given the size of the proposal, that Simon Jones Callahan will be involved in it. I would expect that Kate would be as one of the local members, as would others.
Yeah, is that the reference group that's looking at the consultation, or do you mean the actual the Health Hub meeting?
Not entirely clear. I'm thinking really is the concept of this committee, because I was thinking this committee sort of being involved in the engagement process, not the consultation process. That's clear about the difference there. So I think it would be useful to have some thought from yourselves and some mood from yourselves about how you would like this committee to be involved in the development of this going forward.
Obviously, I can't go. In the past, consultation in the NHS, whoever it has been very poor. Not consultation, but the engagement and so on, and how they then consult. And it would be really good if this committee could look at and help all those guidelines of how they're going to engage. Focus groups can be easily managed, as it were. I think we need to have an input so that actually we allow many people to get involved in that we have some guidelines about how local councillors actually would like that to happen, because it's their communities, and the feedback will come back to the local councillors very quickly. Also including Health like Shropshire. All of those things that we ought to be actually beginning to have an impact on how they're doing this. They haven't had a great reputation so far, they haven't done it terribly well. But then, when you get to the formal consultation, we need to look at how they think they're going to do that, because quite often there are equalities issues around how they consult. So actually, I think that's a really big role for this committee.
Yeah. Well, I think this committee this morning has asked them quite a lot of questions, and they would be invited back to this committee to answer those questions, so that we can take it a step further at a time. Because clearly, as was said earlier, I think that this presentation was a bit too early, because all the entire thing is that they want to build a building big enough for people to move into, and that was it. Not where it is or how it would work. And I think the questions we asked today were very valid, and we do need some answers.
A very fair point. I would point out that the committee is, as a committee, has approved has sent two slightly conflicting messages to the NHS, or CCG, one of which is, or haven't involved us earlier, and the second being, comes us too early. So I would be careful, not be careful, that's not the right word here. So I think at the moment they've presented you with a very sort of undetailed plan at the moment, but they have said at the same time as they're involved in shaping that as it becomes more, as it crystallises in the future. So really you have an opportunity here, you have their ear, you have their agreement that you can be involved going forward. So it's for you to shape at the moment how you would like that, what details do you want coming back, when do you want to see this going forward.
I think if we've given us a rough time, haven't they? So if we put on the agenda for July and engage with Claire in the meantime and say that we welcome shaping it as happened before, we'll bring it back and feed that back to us.
Yeah, I mean, I'd agree with Councillor Kidd's suggestion about the consultation. I think the last agenda item shows the positives of when health and councillors and the council can work together. I think it would be really good for them to share some of the information they're talking about, really as soon as we can get it, in terms of the various impact assessments. It would be nice to have the detail of the previous listening exercise as well. And yeah, I think it might be back to this to well, for me, I would say it's much more priority.
It would be also very good if we could actually see their plan. We couldn't see their engagement plan at all. We ought to be able to have an input on that, the engagement plan itself.
There's a more general point on that, if I may. I mean, it's impossible to see anything on that screen, and I think the new way of working is fine. Some people in the room, some people are on the screen. But if anybody is making a presentation, and this is far more relevant to scrutiny than it is to cabinet getting presentations of that sort, or at least they're in the room and they can hear it. Surely we can connect up to the big screen there. Can't be beyond the bounds of possibility. We can do it for a full council meeting. Surely we can do it for somebody coming along and make a presentation. Because I'm sure that I, like everybody else in the room, sitting there looking at that, could discern any single piece of information from it. And it wasn't the same information that was circulated to us beforehand. And that was has it been, we could have audience, and I got that here, always, but it wasn't. So somebody can have a word with IT and see if we can get it up to the big screen, and the people sitting back in even worse places.
I think right now, if we're going to have scrutiny in here, we probably do.
I think the other thing about that presentation is it brings us back to what happens with the NHS full stop, is the presentation's coming very late, so they can't have been shared and all the rest of it, and actually, had we all been able to put it on our inbox, and it being small enough to circulate, not be stuck in that inboxes and not outboxes, then that would make it quite different. I think the other thing I would really like IT to investigate is something that I've seen at the LGA. Those people that cannot see who's asking them questions, and that's really important, that they should be able to. It is possible, I think, to have a camera that actually focuses on the person asking the questions, so that the people who are working remotely can actually see and have some sort of idea about facial expressions and so on, because that's really important when you're doing something. You can ask a question that sounds okay, but if you're putting the wrong face, actually it's got something much more sinister behind it, or vice versa. So if we could get IT to do that, so that we don't have to drag people miles, but and if IT goes down, you need to have somebody in the room, because there are times when the Wi-Fi doesn't work.
We are evolving very soon. Okay, next meeting is 11th of July.
Can we also please make sure, because it's so important, that the work programme includes, at some point, just a brief report back on what can do the RSH and so on, because members of this committee are not all on Mosque, which will be dealing with all of that. And actually, local members here need to have that report back.